Brandy's doing that Thursday. We're just doing trauma today.
Trauma, we can pay attention to the end.
Yeah.
This is the cooler part.
Well, I hope you pay attention about that.
I'm just saying, give me all burn.
Alright, we're going to go ahead and hit chapter 29, which is trauma systems, and hopefully go ahead and knock out bleeding today too. We'll go to 11:30. If y'all need a break in between then, we'll take a break. And then we'll come back and we'll hit again. Who in here has something that you can take a test on in Canvas with you right now? Alright. So raise your hand if you need a laptop to take it. Okay. I'll probably just push the laptop card up when we do that pre-test later this afternoon instead of going to the computer lab. So obviously, like I said when we were going over the syllabus, trauma is trauma. Forces are the same as they were, in advanced EMT and EMT. Injuries are the same. We're just going to get a little bit more in depth, and the whole purpose of this first chapter, Trauma Systems and Mechanisms of Injury, is to help you to identify the forces that were in action that caused the injury when you arrive on scene. Now, you don't have to get real in depth with it like, an investigator would on a car accident or something like that, but just being able to identify the severity of the mechanism of injury, to be able to identify where the impact happened, approximate speed, and just understanding the forces that goes along with it will help you to identify the injury a little bit better. What is one of the most important things to look at when we're looking at a traumatic scene to determine the severity of an injury? Mechanism of injury. Mechanism of injury can come into play in several different ways. Number one, it can kind of give you a reasonable idea of the type of injury that you'll be faced with. Number two, it can help you if you've got a patient that, let's just say, that was involved in a bad car accident. Let's just say it was an accident where you had the death of another passenger in the same compartment, but this patient's up walking around and talking and moving and not really complaining of anything. Are you going to treat that patient just based off the way that they present themselves, or are you going to treat that patient more along the lines of what's based on the mechanism of injury? Mechanism of injury. Now, of course, you may not have anything to really treat other than, spinal packaging and things like that, but that's one of the criteria to send somebody to a trauma center is mechanism of injury. I could be standing up here just involved in a bad rollover or something like that and talking to you, not really complaining of anything, but I still probably need to be evaluated at a trauma center. Why is that? Alright, because you may have internal injuries, head injuries, things that may manifest a little bit later, right? What happens to the body whenever it's insulted or injured? Alright, so it may eventually go into shock, but what happens to body tissues? Okay, it does compensate, but I'm just talking about, just think on just a linear focus here. Swells. What causes that swelling? What's the process called? Inflammation, right? The inflammatory process, right? So the body has the inflammatory process. Part of compensation, right? Part of trying to maintain homeostasis. But the reason why some of these injuries don't show up until later is because of that inflammatory process, right? That's why sometimes head bleeds don't show up on a CT scan or an MRI until 24 hours later. That's why somebody with a spinal injury could be moving around the first couple hours, and then as that spinal cord, that nervous system swells, starts compressing, then they start having deficit. And so looking at the mechanism of injury, that's going to help us identify these possibilities, and it's going to help us provide more definitive treatment for the patient. These are just your competencies. So looking at trauma, trauma is the primary cause of death and disability between the ages of 1 to 44 years of age. What's important to remember about this being the primary cause of death and disability is that it is the primary cause of preventable death and disability. Trauma has placed one of the largest strains on the healthcare system as a whole. What do you think are some important things to, or what is important about trauma? What is important about trauma prevention? It's education, right? So, our role, a traumatic scene starts with us, all right, or with the healthcare profession in general. It starts with education, environment, and enforcement. What I mean by that is education. We're going to educate the public. We're going to have programs that are going to educate the public on injury prevention. Several common ones. Children's Expo. They give out bicycle helmets, students, right? Most fire departments you can go to have your baby seat checked, and they can show you the proper way to put your baby seat in, right? And even on the medical side, the things like we did at the Lee County Fair, doing the hands-only CPR. Education. Environment. And we're looking at injury prevention, trauma prevention, environment. What type of environmental changes need to be made? Now, I'm not talking about climate change and global warming and all that. I'm talking about the specific environment. For instance, we've noticed, I'm just giving a scenario here, we've noticed at a playground at Opelika Middle School, there's been several injuries. Students falling off of the monkey bars onto the hard pavement. What environmental changes would aid in injury prevention?
Not putting concrete under them.
All right, so taking something like the rubber mulch and spreading it out on the playground, right? Maybe taking out the monkey bars and putting something a little bit lower to the ground, all right? And then you've got enforcement. What do you think enforcement is? So enforcement is looking at what we've educated the public on, we've changed the environment, and now we're going to kind of enforce these regulations. All children must wear bicycle helmets when they ride their bike. All children must be strapped into a car seat. Those kind of things. That's important to remember because, like I said, trauma and traumatic injury is one of the biggest strains of on the healthcare system itself. What is considered an epidemic? What is an epidemic?
An outbreak of
Something affecting a bunch of people.
All right, so something affecting the health of a group of people, right, of a society. You know, there is a Ebola epidemic going on in Africa right now, all right? There is possibly an epidemic of that MERS disease right now that's breaking out. Well, the Centers for Disease Control has always put out publications, has always put out information on epidemics affecting the medical aspect. But years ago, they got together and said, hey, we've got all these people that are dying from these traumatic injuries. We've got all these people that are dying from car accidents, that are dying from falls. trauma itself is an epidemic too. It is a medical or a issue that's affecting the overall health of a society. So the CDC started regulating trauma. All right, they started putting out publications, and that's where those 3 E's of trauma prevention came from as part of something called the Hadon Matrix. I can talk like that now because I'm educated, right? So when we get out on a traumatic scene, all right, and so we naturally go to thinking of car accidents, but there's tons of traumatic scenes, right? An overall analysis of that scene is vital to helping us identify the injury. When does this analysis usually take place?
Like starting from when you get the call.
Yeah, it's really starting from when you get dispatched, right? Then you're getting, while you're dispatched, you're en route, you're formulating all these hypotheses in your mind of what can go on. I do it all the time. Any of y'all that work, you think of worst case scenario, you know, and what could be going on, what could be happening, what are we going to do? We're going to get the helicopter, we're going to get extra help, we're going to get this, we're going to get that. Then it continues by doing your windshield survey while you're surveying the scene. And then we're going to do our scene size up when we get out there in our primary assessment, right? So, injury has to occur when an external source of energy affects the body beyond its ability to sustain and dissipate energy. So under normal circumstances, our body is able to sustain energy and to dissipate it. I'm walking up here right now in front of you. My body can sustain the energy that is created by, or that is dissipated when I walk and when I touch the ground. I'm not getting a blunt force trauma when my foot hits the ground, right? Now, if you had a cannonball shoot up through the floor and it hit me, my body can't tolerate that. My body can't dissipate that energy in a proper way. So there's several different types of energy that's dissipated in the body that can cause trauma. You've got your mechanical energy. That's going to usually be the most common type of energy dissipation that causes injury when we see in the field. Then you've got your chemical energy. Energy released from chemical reactions inside the body, outside the body. Electrical energy, obviously from electrocution, and barometric energy. What does barometric mean?
Pressure.
Pressure. All right. What would be an example of an injury that's related to a mechanical energy dissipation?
Fall, blunt, something.
All right. Give me something specific.
Car wreck.
All right. Car wreck. All right. Give me something even more specific. An injury.
A head-on collision where the seat belt holds the person in place when they hit the whatever object they hit. Their body's going to keep going until it hits something that's going to stop it.
Okay, so where is all the energy at force? Where are we looking for injuries? He said a head-on collision where the body keeps going, it's held in by the seat belt, and it makes a collision with the steering wheel.
Chest, abdomen, head trauma, they're not wearing a seat belt, they didn't get the
Okay, let's just say, well, you said they were restrained, so let's just say they're restrained. So where's the dissipation of energy occurring? The seat belt, all right. So the first dissipation of energy is going to be that acceleration, or that rapid deceleration, right? Bam! All right, so this energy has hit, the body's still going, all right? So now the energy that's in the seatbelt, the potential energy in the seatbelt, is going to disperse energy into the body, blunt trauma. All right, then the body, when it connects to the steering wheel, then we're going to dissipate energy from the steering wheel into the body. Chemical energy, specific. Give me a specific scenario where we would see an injury from a chemical.
Like lye or something getting on your skin?
Okay, so you get lye. Does lye cause a reaction on your skin? All right, so I got some lye on my skin, and now it's creating energy. It's creating heat, right? By having a reaction on my skin. Electrical energy. Example. All right, walking around minding your own business on the golf course, and you got struck by lightning. All right, that one's pretty easy. It's either going to be an electrocution or a lightning strike. And then barometric, scuba diving, where you've got those extreme changes of pressure. An example that comes to my mind, I think it was on Tales from the Crypt a long, long time ago about these astronauts that were up in space, and these two astronauts got into a fight while they're doing a spacewalk, and one of them ripped the helmet off the other guy and it crushed his head in. So here's some of your terms that you've seen before. Biomechanics, the study of physiology and the mechanics of living organisms. Everything relates back, when we talk about injury sustained, relates back to kinetics. The study of the relationship among speed, mass, direction of force, and physical injury caused by these factors. So any injury that is sustained is going to be the result of something affecting the speed of the object, the size of the object, the direction of the force of the object, and what physical injury was caused by the object making energy. Your factors that affect your types of injury. The ability of the body to disperse injury delivered. What is going to come into play with the ability of the body to disperse energy delivered? This is some of that special population stuff coming in now. All right, you said size, mass, size, your density. I'm more dense than probably some real small people. All right. Age, the ability of the body to withstand. All right. Younger children, their bodies are more pliable, more flexible, so they can sustain. All right. Position. Elderly people, they're not able to sustain because they start having bone mass degradation. All right. An example: you've got an NFL player who can withstand all kinds of blunt force, hitting, tackling, and all that. You get an 80-year-old female out there, or an 80-year-old male out there, trying to run that ball, it's going to cause physical injury, right? So your size of your object, the velocity, acceleration, or deceleration, and then your affected body area. The larger the area of force of dissipation, the more pressure is reduced to a specific spot. The larger the area of force dissipation, the more pressure is reduced to a specific spot. What does that mean? Pretty much the bigger the mass that hits you, the larger the body area. All right? The smaller the mass, more of a specific area that's going to cause injury. All right? If I got hit by a wrecking ball that's huge, it's going to cause injury all over me. Right? But if you throw a medicine ball at me as hard as you can, it's just going to cause injury in a specific spot. Right? So, body parts in particular, they play a role in energy dissipation. Organs especially. Your hollow gas-filled organs, all right, they are going to, the gas is going to be more easily compressed, causing injury more to the outside. And then your liquid-containing organs, they're less compressible, all right, or your denser organs are less compressible, so that's going to cause greater injury to the organ itself. Does that make sense? So just looking at this car wreck right here, what are some of the forces that come into play here? All right, first off, is this a frontal impacted, lateral impacted? Yeah, it's more of a frontal lateral. It's kind of on both. So we're actually, especially in the passenger compartment, we're looking for injury sustained frontal and lateral, right? With this truck, this is going to be a frontal impact, all right? So what are some of the factors that are going to affect the mechanism of injury here?
If the passenger was restrained,
Okay.
Speed at which the accident occurred.
All right, so your speed, restraints, speed and size, velocity. All right. How fast is this truck coming? And is this car stationary, or are they meeting together, right? Because if you have two objects that are going at a certain speed, those two speeds combine, all right? So we're looking at the size, we're looking at how fast, we're looking at injury patterns, typical injury patterns that we would expect with this type of vehicle collision. Just some terms here. Velocity, distance per unit of time. Acceleration is your rate of change of velocity. Your gravity. We all know what gravity is. It's the downward acceleration imparted to any object moving toward Earth. Then you've got your formula for kinetic injury. Now, of course, energy. I'm not going to expect you to do all these physics formulas and stuff like that. You're not going to do that out in the field. But you need to understand that in the dissipation of kinetic energy, it's going to involve the size and how fast that object was going. So, the kinetic energy of a car in motion that stops suddenly must be transformed or applied to another object. That's going to get us on a little bit ahead, but is energy created?
No.
Can energy be destroyed?
No.
No. Energy is stored and released. The angle, the difference in sizes of the two vehicles, and then the restraint status, that's going to affect the dissipation too. So basically, the bottom line is that it comes back to an injury is caused by energy dissipation, right? So, our law of conservation of energy. We just talked about this. Energy can neither be created nor destroyed. Energy dissipation is a process in which the kinetic energy is transformed into mechanical energy. You've got certain protective devices that can manipulate the way the energy is dissipated. What are some of the protective devices that are on vehicles? Airbags, restraint systems. Have y'all heard of crumple zones? Crumple zones are areas of the bumpers where they're designed to crumple. That's why you see these new cars, when they get hit, they crumple up, especially on the front and the back. They're designed to do that, to absorb the energy. So Newton's first law of motion, a body at rest will remain at rest unless acted on by an outside force. Alright? And then his second law of motion, the force an object can exert is a product of its mass times its acceleration. My water bottle right here, does it have energy? It has energy stored in the form of what type of energy? Potential energy. I'm going to take my water bottle and slam it. Y'all just saw me throw like a girl. I'm going to pick it up with my right hand. I'm going to just take it and slam it on Hudson's head. What's going to influence how bad he's hurt by my water bottle? Alright, if I throw it like a girl or a boy, I don't need to spend a whole lot of time on that. There's probably a lot of girls in here that could beat me up. How hard I throw it, how light I throw it. How about whether my water bottle is full of water or whether it's empty, right? Because if it's full, it's going to have a greater what? Mass. If it's empty, it's going to have a lesser mass. So it's not going to have as much force behind it to cause the injury. Force is mass times acceleration or deceleration. So that's just what we just said. I've got an empty water bottle and I throw it real lightly and it's just going to bounce off his head. It's not going to cause near as much injury as if it was heavier, full of water, and I slammed it in his face, right? And this is where your G's come in. The G-force. The G-force. Be a cool band name. So getting on into blunt trauma, Blunt trauma is going to be what? Injuries caused by a blunt object or hitting something, right? It's not going to penetrate the body by an external object, all right? It's going to be me taking that baseball bat and hitting Ryan in the head, right? Now, if I had a sharp stick and slammed it in his face, then I'd just cause a penetrating wound, right? You've got your phases of trauma. Phase 1 is the deceleration of the vehicle. Phase 2 is deceleration of the occupant. Does the occupant and the vehicle stop at the same time? No. Alright? Phase 1, the vehicle strikes another object and is brought to an abrupt stop. It hits that big tree and stops. What happens to that energy that was being used by that vehicle until it came to that abrupt stop? It's transferred into the object or the tree, right? Phase 2 starts during the sudden braking and continues during the impact of the crash. It results in deceleration, compression, and shear trauma, which depends on what? What is the injury going to depend on? What have I been saying for the past 10 slides?
Speed, restraint, velocity.
Yep. Size, what area was impacted, how fast the vehicle was going, and what protective mechanisms were being used in the vehicle.
I was just laughing at his face as he's close to the window.
Mm-hmm. I guess it wouldn't be as bad as if he just walked around in normal life looking like that. Phase 3 is the deceleration of internal organs. Phase 4 is your secondary collisions, and then Phase 5 is additional impacts received by the vehicle. So it just all goes back to what we've talked about in previous classes. All right, you've got the vehicle impact, you've got the body impact, you've got the organ impact, then you've got the other objects. It's the picture of the present in the back of the car that comes slamming into somebody's head. All right, let's move on through this because I know that y'all know these impacts. A frontal or head-on impact, what are we looking at? What type of injury patterns are we looking at on frontal collision? All right, so we're looking at the up and over. Explain. The up and over. All right, up and over, hit the windshield. What types of injuries are you looking for there?
Head trauma.
All right, head trauma. What? All right, cervical spinal, upper thoracic spinal. We're looking at abdominal. We're looking at thoracic. All right. We're going up and over. All right. The down and under pathway.
You're looking at lower system trauma, legs.
All right, so depending on the force, depending on the speed, depending on the size, depends on the injury. If it's a significant mechanism of injury, frontal impact, we're probably looking at bilateral compression fractures, right? We're looking at all kinds of lower extremity injuries, lower abdominal, all right? Depending on how close we are to the steering wheel, depends on our other injuries, and then we're also looking at lower back injuries as well, all right? So you've got your down and under and your up and over. Your lateral, what are we looking for? So the obvious injuries are going to be the injury sustained at the point of impact, right? The lateral side of the body. But what other injuries are going to be sustained?
Cervical, spine, head trauma.
All right. So I heard internal organs that's sustained from the dissipation. What'd you say?
Lateral motion of the head.
Yeah, lateral spine injury. All right. What? All right. Hip fracture, hip dislocation. If they are restrained, those seat belts are going to hold them in place, and so we're causing more force, and those seat belts are tightening down. So we're looking at contusion type injuries on the opposite side. If they're unrestrained, then we're looking at a whole plethora of injuries. Rear impacts.
They're dead.
Yeah, that's pretty rough.
Pretty bad.
Rear impacts have the most survivors and the highest lawsuits, I would assume. One call, that's all. Whiplash. What is the progression of a whiplash type injury? What's that? Okay. All right. Depends on the severity of the mechanism of injury. It will get worse and worse. All right, especially if it affected the spinal portion. What causes it? You've got that rapid hyperextension and hyperflexion, right? What? All right. So depending on how hard you're hit, you can have your coup contra coup, brain injuries, right? And again, that is that kinetic energy that is being displaced from the vehicle that hit you, transferred into that car, transferred to your body, right? Rotational or quarter panel. In my other class, they use that example of that little sedan that's on top of the big old caddy. Y'all remember that picture? The big old tank. So this occurs when we hit and it spins, right? So we're looking at all kinds of rotational type injuries as well. And depending on where it's hit also is going to depend on the injury. Now your rollovers, that's going to cause probably the most systematic trauma, right? Because there's so many forces at play here. One of the most important things that's going to depend on the type of injury with rollover is whether they're restrained or not. All right? Because if they're not restrained, depending on the forces, you're going to have all kinds of injuries. All right? You may be ejected, maybe bounced around like a pinball inside the car. So seat belts, obviously, they're your restraint systems, and they stop the occupant. They stop the motion of an occupant traveling at the same speed as the vehicle. And so they're going to keep you from getting thrown out or obtaining even worse blunt force trauma, but seatbelts in themselves can cause injuries as well, right? Any of y'all ever been in a car accident where your seatbelt tightened up on you and then that airbag came out? I mean, it practically sucks the life out of you when it tightens up like that. So we're looking at chest and abdominal contusion, burns, all right? Also, neck and back injuries as well. Airbags. So the accelerant that's in an airbag is a chemical, right? And y'all ever had an airbag deploy on you? The inside of the vehicle gets all smoky and powdery and all that. So that is a chemical. Most often injuries that you're going to see with an airbag is going to be where the driver had their arms on the steering wheel and that thing popped out and that canvas, it caused those friction burns on the arms. All right. I know that y'all all felt an airbag, right? Y'all know that it's made out of the Chuck Taylor material, right? The all-star material, the canvas stuff. Remember on the intro credits to The Simpsons where Maggie's driving, she has a car wreck, and the airbag comes out and she falls asleep on it? Yeah, it don't work like that. Airbags have been reportedly to reduce deaths in direct frontal crashes by about 30%. Have y'all seen that little video? I don't think it's real, but that little video of the little old lady with the bag that's walking across the front and that dude starts honking the horn? That's pretty funny. I hope it was real. Motorcycle crashes. What are we looking for in motorcycle crashes? Signs of life. Yeah. All right. So everything that y'all listed off here is all going to depend on what? How fast they were going, what they got hit by, where they got hit. It's where all your physics come in. Now, bike riders should have their protective gear, their helmet, their leathers, their boots, and stuff like that. When I rode a bike all the time, I just wore tennis shoes and shorts. I mean, most often in Alabama and the 100% humidity, you're riding a motorcycle, you don't want to put leathers on. All right?
I think it would offend motorcycle people if you call them motorcycle.
Did you do that?
No, you just did.
I I said motorcycle.
Yeah, but he was saying you drove them both in.
It was a joke. You know, he didn't get it.
Yeah. No, I had a hog. So of course our scene size up, we've got to look at how bad the motorcycle was deformed, where it was impacted, how far did it slide. Alright, because depending on the surface and the length of how far it slid, that could cause significant injury to the motorcyclist as well. And then helmet deformity. So you got 4 types of motorcycle impacts. You got your head-on, your angular, your ejected, and laying the bike down. So your head-on, obviously, it's going to be a head-on collision with a motorcycle, right? What are some of the things that would affect injury with a head-on collision with a motorcycle?
If they hit the vehicle in front of them, they got thrown off.
All right, the size, the kind of vehicle, did they get thrown off? They're not restrained. What they landed on. I had a guy that I used to go to church with. He was a motorcyclist. He told me a story one time of this guy that he knew on it was an old Honda, and on the old Honda motorcycles, their gas cap is raised about 2 inches off of the gas tank. All right, the ones now it's inverted into it, but he actually hit somebody head on, and if you can imagine riding a motorcycle. When he hit, instead of going head first, his whole body just kind of transferred, and he got caught as he was going over. Yeah, by that gas tank, and it left parts of his body on the motorcycle as he traveled forward. That what? Well, whether he wanted it or not, he did. You got your angular impact. And that's going to be where the motorcycle strikes an object or another vehicle at an angle so that the rider sustains direct crushing injuries, all right? So it hits and then it gets caught. Ejected, obviously, that'll usually be part of these other impacts as well, all right? And then laying the bike down. When I learned how to ride a motorcycle, and anybody that rides a motorcycle consistently knows about laying the bike down. It is actually something that a motorcyclist learns to do as a protective maneuver if they're in an accident. And what it does, especially if they've got their protective clothing on, is as they see that they're about to make impact with something, they learn to lay their bike down, all right, so that the bike goes on, they get slowed down by the surface, and they don't make direct impact with the bike, all right? So we're definitely going to be looking at multi-system trauma if it's an ejection or a frontal collision, all that. If it's a laying the bike down to where they don't actually make impact with anything, what type of injuries are we going to be looking for? Road rash mainly, right? When should we remove the helmet? If we can't get access to the airway, all right? Or if the helmet is not a properly sized fitting helmet, right? The helmet should be cut if it can't be removed without further deformation. All right, so we should get the helmet off if it's impeding airway, or if it's not allowing us to cause, if it's not allowing us to properly restrain the head. We are pedestrian injuries. You got your first impact where the auto strikes the body. Second impact where the adult is thrown on the hood or the grill of the vehicle. What happens to the kid?
He goes under.
All right, they'll either go under or forward, right? And then you've got your third impact where the body strikes the ground. So you've got your car impact, body impact, ground impact. What does an adult do when he sees a vehicle coming to him? Turns, right, or tries to run. What does a kid do? Deer in the headlights, somebody please stop this big vehicle from coming and hitting me. Again, this is going to depend on the mass, the direction or the speed in which it's going, and the size, where the bumper is, right? I get hit by a Honda, I'm going to sustain primarily lower injuries, right? I get hit by a big F-150, I'm taking the full brunt to my whole body, right? You've got this new triad, the Waddle triad. The Waddle. The pattern of injuries in children and people of short stature. Bumper hits the pelvis, chest and abdomen hit the grill, the head strikes the vehicle in the ground. Ouch. So you're looking at all kinds of injury here. We got about 20 minutes. Do y'all need a bathroom break or do y'all want to? Or actually, we're going at 11:30. So, do y'all need a bathroom break right now? Yeah? Okay, let's take a break.
Look up, I got a video I want to show you about my
Yeah.
Every time I get hungry, I also talk about
Let's talk about falls from heights.
That's bad.
Obviously, your severity of injuries, how big you are. See, that heat is blowing just fine. Y'all ought to warm up now. I'm going to slow down. How big you are, how high you are, whether you got Don Juan syndrome or the lover's leap. What is that?
Either of them.
What? Don Juan syndrome or lover's leap?
No, I just asked because I didn't know.
I don't know. I've never heard of lovers.
Somebody that knows, tell me.
We didn't think it would be like, they love each other, we're going to kill ourselves together.
Oh. And then you let the girl jump and you're like, oh, I got scared.
Knew I had a way out of it.
Place on it. Where is it, the mountains, when they jumped off together?
This is where they'll jump, but then they'll land on their feet, causing compression injuries.
So that's a lover's leap.
Yes.
I told you that was crazy.
Golly, guys, that can't happen.
Go to the mountains, go to, no,
I'm not saying
leave it.
feel themselves.
I'm sorry, but it is what it is.
You're turning it down, but it has
Dude, it's summertime. Why are you wearing blue jeans? Or khaki pants?
Because this is my job.
We're not going to tell anybody.
Y'all can get over it. Y'all can get over it. It's going to be a long summer if y'all can't bring yellow jacket or something.
Should have worn you some scrubs.
Penetrating trauma. Things that are going to factor into the type of injury. What penetrated them? How big was it? How small was it? Was it sharp? Was it more blunt? What was the velocity? Your low velocity are going to be wounds caused by something in your hand stabbing into somebody. Your medium high velocity are going to be your projectiles. This guy got his hand blown off. Severity also depends on the anatomic area. What part of the body was injured? How deep was it? The length of the blade. Your gunshot wounds depends on your type of firearm. Is it a high velocity rifle or is it a lower or medium caliber, medium velocity shotgun or handgun? The physical design, the size of projectiles. Some of y'all firearms experts, tell us the difference in some of the projectiles that are shot from a gun.
I mean, say if you have like a little 22.
I said an expert husband. I'm just kidding. Go ahead.
Like a full metal jacket type bullet? I mean, you can go
Yeah,
like
yeah.
a full metal jacket versus a hollow point. Hollow point's going to expand and cause more trauma. If you have a smaller bullet like a 22, it'll go in there and bounce around and screw everything up. You shoot somebody with like a shotgun slug, it usually just goes in place, but still causes damage because it's larger, lower velocity. I mean,
Right.
you know, you shoot somebody with a 50 cal and they just disappear.
Yeah. So what Hudson was saying is like somebody gets shot with a 50 caliber rifle. It's a high velocity, It's got a lot of impact, a lot of force behind it. When it hits, it just kind of turns everything to mush, right? If you're lucky to even have any mush left. All right, shotguns. You've got several different types of cartridges for a shotgun, right? You've got the bird shot, where it's just a bunch of little pellets that kind of sprays out. All right, then you've got buckshot, which is going to usually be like 3 pellets. And then you've got your slug, all right? And those are going to cause more of a tumble type injury on the inside when they hit, because they're going at a slower velocity. Then you've got like a rifle, a 22 even is a rifle, but it's on the lower end, and it's going to cause a penetrating injury, and then it's usually going to be slowed down by the body, and it's going to tumble around on the inside as well. With any penetrating injury, what do we look for?
An entry and an exit wound.
An entry and an exit wound. I just talked about that a little bit. With gunshots, what type of tissue is involved? All right. Is it a high velocity that's impacting the head? Is it a low velocity buckshot that's spraying the back? It depends on the anatomical area. And then the entry wound is characterized by the effects of the initial contact and implosion. So depending on the caliber, depending on the type of ammunition that's being used, you may have a different type of entry wound. Okay? Your density, the compressibility, the velocity, and the fragmentation of the missile. Fragmentation, is it designed to kind of break apart? Is it designed to kind of, what's it called? The Full Metal Jacket? Mushroom out? What is it designed to do? The projectile creates a permanent cavity, that's called cavitation in the body. Where is that energy going to be dissipated to? The surrounding tissues, right? So your entrance wound is usually going to be a little smaller and a little more clean, because the energy hasn't dissipated yet. So it's going straight in, and then as that energy dissipates, it expands out of that cavitation, and if it has enough force to go through and create an exit wound, it's going to explode out of the back. Alright? So that's why it's very important when you do your traumatic assessments, your trauma assessments, if you've got an entrance wound to the chest, you're not fully managing your A and your B unless you check for an exit wound, because that's part of your thoracic cavity and that's part of your airway injury management. Your wounding potential depends on the powder charge. All right, how much energy is going to be created whenever the projectile is charged out of the weapon, the size and number of pellets, and then all this that you see here as well. The barrel length, the type of choke at the end of the barrel. Why are sawed-off shotguns illegal?
They're deadly.
They cause a lot bigger impact at close range than a full-length shotgun. That's probably not the only reason, but that is one reason. It is pretty imperative that you look at a couple of factors whenever you are assessing a penetrating wound, whether it is a knife or stab wound, or it is a gunshot wound. Particularly going back to the knife wounds, the stab wounds, you need to know what was used, the length of the blade, and also the size of the person causing the wound. Alright? Why?
Judge force.
Because I can cause a lot more force when I stab somebody than a person that's 75 pounds, right? Because I've got more density, more mass behind me to force it. With your gunshot wounds, you definitely need to know what was used, the caliber of the rifle or the shotgun, alright, what type of ammunition, also distance. How far were they? What angle? What angle were they shot at? All right? What bullet was used? We're going to look at powder residue around the wound. A closer range, you're going to have more powder residue because that powder sprays out of the barrel, if I'm not mistaken, whenever you shoot. And so at a closer range, that powder is going to spray on the individual. And then, of course, your entrance and exit wounds. You got your blast injuries. Your primary blast injuries, these are going to be injuries that are caused by the pressure wave that is generated by the explosion. What's going to factor into that? How big of an explosion? What was detonated? What was charged? Right? How close are you? How far away are you? The closer you are, the greater the risk of injury. Your secondary is going to be the primary is the initial shock wave. Your secondary is what was in the detonation, or what was around it that caused that after the explosion that got projectile that went flying. That's what I'm trying to say. You also have a blast wind, and then the flying debris may cause blunt and penetrating injuries. All right. Then you've got your tertiary. So you've got your primary where you've got the pressure wave, then I've got all the shrapnel coming at me, and now I'm thrown back and I hit the ground or I hit the wall. That's my tertiary. Your ground shock is your displacement when the body impacts the ground. And then your quaternary is going to be the miscellaneous events that occurred during an explosion. These are going to be your respiratory injuries, your burn injuries. You know, did you get thrown and then a car get thrown on top of you and crushed you? That kind of stuff. Your quinary blast injuries, these are caused by the biologic, chemical, or radioactive contaminants. These are your dirty bombs. These are your weapons of mass destruction. All right, this is your biological warfare type stuff. All right. When the object is detonated, what causes the pressure wave? The increased pressure of the large volumes of gas. All right, that pressure, that atmosphere, is gas that's being expelled away. All right. You've got your propellants. These are explosives designed to release energy relatively slowly. What would be a propellant? Like a missile?
Well, I mean, explosive designed to like you got like the space shuttles. They were designed to burn slowly. That way they can launch and stuff.
You kind of guess.
Propellants.
Okay. When I think about propellants, I think about like gases, like things that will accelerate a fire or something like that. All right. It's so hot in here now. Just like you know that. A couple of other terms. You got your blast front, your positive wave pulse, your shock wave, and your negative wave pulse. All these waves are going to cause types of injury. We already talked about some of the physics behind the explosions. Obviously, if you're in an enclosed space, an explosion is going to be more damaging than if if I set off an explosion right here in the middle of the room. It's going to cause a lot more injury because we've got that pressure that's going to be exerted on all of us. The pressure has caused the destruction at the interface between tissues of different densities and the interface between tissues and trapped air. Now, what tissues, when we talk about the tissues, how are the different organs or the different tissues in the body going to react to a blast type injury?
Well, your fat's going to absorb more than your muscle is.
All right, so your fat would absorb more, your muscle would transfer it more. What about your hollow versus your solid organs? All right, so your solid organs, they're going to sustain more damage, right? Because they are more dense. All right, your hollow organs, they run the risk of what? Blowing up, right? Exploding out because of the increased pressure. What is the most common body structure that is affected by a loud blast? Your eardrum. Your eardrum. So often you may get called to somebody that was around some type of explosion or something where they're bleeding from their ear from a ruptured eardrum. I just told you all that. Primary pulmonary blast injuries occur as contusions and hemorrhages. Primary pulmonary blast injuries. So primary injuries affecting where? The lungs. If there's any reason to suspect lung injury, administer oxygen, get them out of the environment. All right? Your assessment and management, obviously, get them out of the environment if it's still hazardous. Form your general impression, make sure it's safe for you. Then do your assessment, do your normal assessment. Multi-system trauma. I hope y'all are getting warm. Are y'all getting warm?
Good. Is the heat on?
Yeah. When you bump it up, that's what I'm telling you. You bump it up just a little bit, it's going to be one extreme or another. Well, multi-system trauma. What is important to remember about multi-system trauma? The more systems involved, the greater the risk of mortality and morbidity, right? If I've just got an isolated musculoskeletal injury, then I stand a pretty good chance of surviving, right? But if I've got multi-system injuries that involve my musculoskeletal system, my cardiac system, my pulmonary system, I've got a lot more to work with now, right? I've got a lot more that's going against me. What's very important about multi-system trauma, and all of y'all have been on clinicals, I hope y'all all got to experience a trauma where there was multi-system involved, not for that person's sake, but for your sake. You've got to prioritize, right? What's important about multi-system trauma is that unless it's bright red spurting blood, musculoskeletal injuries are usually going to be the most gruesome, but usually the lowest priority, right? Just like with any other patient, what is your priority? Airway, breathing, circulation. The biggest change that comes with this when you have multi-system trauma is you've got airway, breathing, and circulation, but as part of your airway, breathing, circulation, you're going to incorporate what management? Shock management, right? Shock management. What is the number one most important treatment for a multi-system trauma that will determine, or not necessarily determine, but will either greatly improve or greatly reduce mortality and morbidity? It's not a skill. Transport, immediate, rapid transport. Identification of the nearest trauma facility, identification of appropriate transport vehicle, and getting them there. What is your ideal time on scene? 10 minutes at a max. 10 minutes at a max. Ultimately, you want to get there, scoop them up, stabilize them, get them to the hospital within 10 minutes. You've got, they call it the platinum 10 minutes in your book. You've got the golden hour. What is the golden hour? From the time the injury occurred, from the time the event occurred, to the time that they're getting cut on surgery, right? That's not a very long amount of time if you consider we're flying a patient off of mile marker 51 on I-85. We're flying them to Columbus. You know, the whole transition of getting the helicopter there, getting them up in the air, that's going to be at least, what, 15, 20 minutes? Maybe, if that short of time. And then I don't know how long of a transport it is, maybe 10 minutes from there to Columbus. Anybody know? 11 minutes? All right. So you got your first half hour of the golden hour used up, right? Then you got to get your trauma team in. You got to get your trauma surgeon. So even if you're moving with extreme haste, you're barely getting a patient. If you fly them out, you're barely getting them there within that hour. Does everybody understand morbidity and mortality? Morbidity and mortality is what all your evidence-based research looks at. Morbidity and mortality, the reduction in morbidity and mortality is what your job is based off of. All right? Morbid. Morbid means death, right? So morbidity is going to be death sustained from an injury or illness. Mortality. Mortality doesn't mean they died, but mortality means that they've got a lasting deficit. So your whole goal, the goal for any call, is to get that patient back to the state of life they were in prior to the event. All right? And it starts with us. All right? So all your evidence-based practice, the golden hour, the platinum 10 minutes, all this stuff is derived from evidence-based practice. They followed these trauma cases for years and years and years and realized, hey, if I can get a patient off the scene in 10 minutes, they've got a higher chance to live. If I can get this patient onto the OR table within an hour, they've got a higher chance to live without lasting deficit. All right? Does that make sense? You'll hear that a lot throughout trauma. So your trauma score. So we've got all kinds of scores that we do, right? Our trauma score. That's going to come into play. That's going to be very important when determining trauma center, when determining air transport. So our GCS is going to be very important. Normal GCS is what? 15. If we got a GCS of 14, that means something's wrong, right? Our respiratory rate. How good are their lungs expanded? Our systolic blood pressure and our capillary refill. Lowering systolic blood pressure indicates what? Shock, decompensation. All right? Collapse of the vascular system, the cardiac system. You know how to do a GCS at this point, I hope. Do I need to spend a lot of time on this? Y'all be able to identify GCS? The revised trauma score is used to assess injury severity in patients with head trauma. This includes your GCS, your systolic, and your respiratory rate. Your scene size up. We can speed on through this, I think. Most importantly, when we're on any traumatic scene, any scene for that matter, what is most important? Your safety. Safety of yourself. Safety of your partner. Safety of your patient. Safety of your bystanders. Right? Who's responsible for safety? You are. Your partner is. The firefighters on the scene are. You're all responsible for each other's safety. A trauma scene is dynamic, meaning it's ever-changing. Just because you arrive on scene and you don't identify any threats doesn't mean that 5 minutes into the scene that there won't be threats that are presenting, right? So everybody's got to be on guard. Consider whether you'll need additional medical resources. Not just additional medical resources, but any additional resources, right? This class, now I know that a lot of y'all have extrication training and rope rescue and all this other types of training. But as paramedics coming out as an entry-level paramedic, you are trained for patient care. You're going to be very good patient caregivers. But unless you've had outside training for extrication and you're working for a service that does extrication, your primary role is going to be what? Patient care, right? You've got to identify your roles on these scenes. Your primary assessments, where your general impression is going to come in. Either this is a really bad scene or we can handle it a little bit. We talked about in detail your mechanism of injury earlier. And then consider whether spinal stabilization will be necessary. You know what to do if they're not breathing, right? We're going to assess all of our ABCs, right? Without B, or without A, you can't have B. Without A and B, you can't have C, right? A couple things that we're going to take more into consideration are going to be the airway structures that would be involved in a traumatic injury. Y'all been doing it since EMT. Whenever you do your rapid trauma assessment, you're looking at trach deviation, JVD. You're checking for equal bilateral chest rise and fall. We're listening to breath sounds. Do we have good breath sounds on each side? We're looking for broken ribs. We're looking for flail segments. We're looking for crepitus. Anything that may inhibit breathing. Now, if we notice an injury sustained in the chest, thoracic area, do we note that or do we address it? We address it, right? Because that is part of your airway management on your sheets. And in real life, you can't move on to circulation unless you're breathing, right? Now, y'all will see some of that kind of changing to where it's all dynamic and it's all going together. But, for all intents and purposes, we manage airway injuries early on. Circulation. This is where we're going to check for our signs and symptoms of hypovolemic shock or hemorrhagic shock, right? What is going to be the most definitive treatment for a person in hemorrhagic shock? Surgery, and to receive what? Blood, right? To receive packed red blood cells. We're going to do shock resuscitation. We're going to give fluids, but the fluids that we give are only doing what? Alright, so it's just filling the gap and it's volume expansion, right? We're just trying to get a blood pressure to push what little bit of blood we've got left. Fluids that we give have absolutely no oxygen binding capacity, right? They have no way of transporting oxygen. They are just a volume expander. Immediate transport. There's going to be those patients that you don't have to go through these whole checklists. You can just look at them and say, crap, they need to go, right? But let me forewarn you, and y'all done clinical, so y'all know. It is very easy to lose track of a load and go. It is very easy to say, I just need to get this IV. I just need to get this airway managed, then we can go. Next thing you know, you're sitting in the middle of the interstate for 20 minutes, and that patient's bleeding out. They're not doing well, when you should have just swallowed your pride and accepted the fact that, hey, maybe I can't get this intubation. Let me just manage it the best I can and get into the hospital. I say that because that's happened to me. That happened to me that first shift that I was back at ETS, and I had that bad wreck on the interstate. I was sitting on the side of the interstate. We were trying to get an intubation, trying to get an IV. We're trying to do everything right for this patient other than the main thing that she needed, and that was to get her to definitive care, right? I can't really do anything but try my best to stabilize in the back of a truck, right? Your platinum 10 minutes, we've talked about that. Try to get a sample if possible. Not always going to be possible, right? Your OPQRST, man, I mean, I'm not saying it's not a good tool. It is a good tool for chest pain, right? Some of this stuff you can't really get. Your sample will be very important if you can get that, simply for the fact that this patient's going to where if they're multi-system trauma? They're going to surgery. Your vital signs. Initially in shock. What happens to your blood pressure initially? Early signs of shock. What? You don't really do anything, right? That's the whole point of compensation, right? It stays usually within normal limits, right? What happens to your heart rate? It goes up. The heart's trying to pump quicker to compensate. All right? Respirations depends on the injury involved. Most often, if they're alert and oriented, if they've just been in a major traumatic event, they're going to be full of anxiety, right? So, sometimes that therapeutic communication comes in even not just with your psychiatric and behavioral emergencies, but with all patients, right? Your physical exam, always do it in a head-to-toe manner, right? If you do it the same way every time, you don't forget. It's the exact same one that you did in EMT, the exact same one you did in advanced, but now you just know how to manage it a little bit more. We've talked about your head and neck. We're looking for decap, BTLS, and all this. Now, one thing that's very important that I want you guys to get into the habit of doing on all of your patients when you're doing an assessment, when you're assessing airway and breathing, is listening to breath sounds. Listening to breath sounds. Because they can tell you so much. Medical, they can tell you so much. Trauma, they can tell you so much. Alright? On your abdomen, we're palpating, right? We're listening. Not really going to be able to percuss too well. When we move on down to the pelvis, we're checking for pelvic stability. If it's unstable, we don't press on it again, right? We don't cause further damage. What's important to remember about the pelvis? If we feel pelvic instability, we need to be concerned with what? Bleeding. You've got your major artery that bifurcates into both sides of the pelvis, right? Your extremities. Very important to check for what? PMS. Then your back. We're looking for deformities, contusions, abrasions, all your decap, BTLS stuff. Then reassess. What's your time? Stable patients every what? Alright, non-stables every what? 5. We've talked a good bit about management of trauma through this, and again, it hasn't really changed. The pathophysiology of shock, no matter what type of shock, always relates back to what? Tissue, hypoperfusion, right? Hypoxia of the tissue. So if we're in a traumatic shock, we need to get what to the tissues? Oxygen. Oxygen. So very important is oxygen, supplemental oxygen, and rapid transport. Now it says keep supine with extremities slightly elevated. It depends on what textbook you read. Alright? I don't really know what the science is behind that. As a matter of fact, everything that I've heard recently is the science says you don't elevate anything. Your fluid resuscitation. What's your formula for fluid resuscitation?
20 cc's per kilo.
So national registry is 10 to 20 milliliters per kilogram initial bolus, right? You want to maintain a minimum blood pressure of what? 90 systolic. That's called what? Permissive hypotension. So, and it's really 80 to 90. Studies have shown that 80 to 90 will keep it perfused. Now, what's the exception with permissive hypotension? Yeah, increased intracranial pressure, head injuries, because the body naturally does what with a head injury? It what? It increases its blood pressure. You have Cushing's triad, right? So it naturally increases its pressure to overcome the intracranial pressure. So you may have to raise your blood pressure a little bit higher, 100 to 110, with permissive hypotension with fluids. Again, another important aspect of a multi-system trauma is the team approach. All right? When we get out on scene, it is not, I'm the senior paramedic, I tell you what to do. It is we are partners. All right? I'll use the example the other day. I was riding with Tara. The first thing right off I told her is today we're partners. We're looking out for each other. We're taking care of each other while we're on the scene, right? You've got to use the team approach. I can just pick on her because she's the only one of y'all that I've rode with so far. But you've got to take that team approach. You cannot manage a trauma scene, a dynamic trauma scene by yourself. You cannot manage but one critical patient by yourself or with your partner, right? you've got multiple critical patients. Get more people on scene. Get more help. Your criteria for referral to the trauma center is a GCS score of less than or equal to 13. All right? Doesn't matter where the deficit is, it's going to be 13. Systolic pressure of less than 90, and then a respiratory rate of less than 10 or greater than 29. Now this is going to be for your traumatic injuries. Other things that you're going to look at: injuries themselves, your penetrating trauma to the head, neck, torso, or extremities, chest wall instability or deformity, 2 or more proximal long bone fractures, crushed, mangled, or pulseless extremities, amputation proximal to the wrist or ankle, pelvic fractures, open or depressed skull fractures, or paralysis. All this stuff is going to be more than what the resources of say a level 3 hospital can handle. So you need to get them to definitive care. Mechanism of injury alone can fall into the criteria for trauma center. Adults greater than 20 feet falls. Children falls more than 10 feet. A high-risk auto crash. Look at the mechanism of injury. Did somebody die? Did somebody get ejected? Was there severe forces involved in this injury? All right? If the patient's age is more than 55, we're looking at more, what type of injuries can their body even handle? What type of forces can their body even sustain? Systolic pressure of less than 110 in 65-year-old or older. Children, they should, if you're in an area that has a pediatric capable ER, they should go to that pediatric ER. Now, I know Columbus Medical Center has a pediatric ER. I don't know what their capabilities are as of yet. But, some of y'all may go work in big areas, Birmingham, Atlanta. Get them to Children's Hospital where they've got specialty resources for them. Same thing with pregnant patients. They've got women's and children's ER. All right? Burns with other trauma. And then, most importantly, out of all that is that you are trained to have a keen eye. You are trained to want to reduce mortality and morbidity of your patients. Sometimes, have any of y'all got that gut feeling that this patient's bad? He may not look bad, but he's bad. The more you're in the field, the more you will get that. And sometimes, if you get that gut feeling, I'm telling you, if you get that gut feeling, go with your gut. What if you're wrong? And then they just went to a bigger facility that they didn't really need to go to. But what if you're right? You've saved their life, or at least had a hand in it. Our trauma centers, the ACS-COT, do y'all know what that is? American College of Surgeons Commission on Trauma. They're the ones that have kind of started regulating ambulances and regulating trauma and all that. They started back in like 1976 and then revamped it again in 96 and then now. See what getting an education will do for you? You get all kinds of useless information in your head. But anyways, they're the group that you get the levels 1, 2, 3, and 4. East Alabama is a level what? 3. They've got the capabilities, I've heard, to be a level 2, but who makes the designation? The hospital itself. The hospital itself. All right. Columbus, what is it? It's a level 2. It's a level 2. All right. You've only got a couple level 1s in the state of Alabama. Now, you've got several level 1s in Georgia and Atlanta. But Children's Hospital in Birmingham, University of Alabama, I think, is it University of North Alabama, and then the University of South Alabama Medical Centers. Those are your 4 level 1s. All right. And on that, let's go ahead and go to lunch.
You gonna lock this door?